Today we shall be talking about tuberculosis of the spine. This is the most common site of skeletal tuberculosis. In musculoskeletal system, the spine is the most common site for the tuberculosis. It most commonly occurs in the dorsolumbar spine. It is always a secondary infection, means that primary infection is in the other organs like lungs, alimentary canal and the renal system. It travels to the spine through hematogenous route, direct spread, lymphatic spread, or through the paravertebral venous plexus of the Batson, which has free communication with the venous plexus of the abdomen. Anatomical classification of the tuberculosis of the spine: paradiscal, central, anterior, and posterior. Paradiscal is the most common. This is the paradiscal. It occurs between the contiguous area of two adjacent vertebrae along with the intervertebral disc. Central. In central part of the vertebral body get affected, leading to early collapse of the weakened vertebra, which is the wedging collapse and the concertina collapse, and wedging collapse is the most common. Anterior. This is the anterior. It is localized to the anterior part of the vertebral body. Infection spreads up and down under anterior longitudinal ligament. Posterior. It involves the pedicle, lamina, spinous process, transverse process. On pathology, in paradiscal type, bacteria lodge in the this is the paradiscal type. So bacteria are lodging inside the adjacent contiguous area of the adjacent vertebra. Then there will be granulomatous inflammation. Then there will be erosion of the margins of the vertebra, and due to erosions, nutrition of the intervertebral disc will be compromised, which leads to complete destruction of the vertebra, due to which collapse of the vertebra occurs. Then cold abscess is formed, which is the pus and tubercular debris, and after healing, bony ankylosis is formed. Every TB heals with the fibrous ankylosis, but the TB of the spine heals with the bony ankylosis. Clinical features: the patient presents with back pain. There will be stiffness, which is the protective mechanism. Paravertebral muscles goes into spasm to prevent movement. Cold abscess is formed, which causes compression, and if there is TB cervical spine tuberculosis, then due to cold abscess there will be dysphagia, paraplegia. The patient presents with paraplegia, spasticity. The patient presents with deformity, knuckle, gibbous and kyphus. In knuckle, there is prominence of one spinous process. It is most commonly seen in compression fracture of the vertebra. Gibbous, which is also called angular kyphosis, in which there is prominence of 2 or 3 spinous process. This most commonly occurs in the spine TB. Kyphus, diffuse and rounded kyphus, which is usually seen in the osteoporotic spine and also in the TB. There will be loss of lumbar lordosis. The patient presents with the constitutional symptoms like fever, weight loss, night sweats and the decreased in appetite. On examination, on seeing the gait, the patient will walk with short steps to avoid jerk of the spine. In cervical spine TB, often supports head with both hands upon chin. Attitude and deformity. If there is tuberculosis of the cervical spine, there will be stiff straight neck, and if there is TB of the dorsal spine, there will be knuckle, gibbous and the kyphus. If there is TB of the lumbar spine, there will be loss of lumbar lordosis, and the paravertebral muscles spasm occurs, resulting in the stiffness in the affected region. Paravertebral swelling will occur. There will be tenderness. There will be limitation of the movement, and neurological examination is done, in which we see the bowel bladder function, motor, sensory, and increase in deep tendon reflex is the earliest sign. And if there is upper motor neural lesion, then spastic paraparesis is seen. In chest, we see the pectus carinatum. General examination is done. On investigations, we do the X-ray of entire vertebra, anteroposterior and lateral view, And in bone, we see the loss of normal curvature of the spine due to paravertebral spasm. Normally it is kyphotic and lordosis, but this will be lost. Loss of lumbar lordosis will occur in the tuberculosis of the spine. There will be reduction in disc space. This is the vertebra and this is the intervertebral disc. And after tuberculosis of the spine, there will be reduction in the disc space. Destruction of the vertebral body fusion. Bony ankylosis will be seen because tuberculosis, after healing, tuberculosis of the spine is bony ankylosis is seen. Kyphosis or angular kyphosis, Cobb's angle in lateral view. In lateral view, there will be formation of the angle. This is the late feature. In soft tissue, we see the paravertebral abscess, bird nest appearance, fusiform abscess, in which there is length is greater than the width. There is globular tense abscess. In this, there is width is greater than the length. It indicates pause under tension and is associated with paraplegia. There will be retropharyngeal abscess if there is tuberculosis of the cervical spine. And we do chest X-ray to see the primary lesion. We do abdominal X-ray to see the psoas abscess. CT scan is useful if the patient presents with a spinal tumor syndrome. MRI is the investigation of choice, as all the soft tissue, cartilage and the marrow changes can be seen, hidden lesion can be seen, and cord symptoms and involvement can be seen easily. Biopsy is done, CT guided or open biopsy can be performed. Myelography is done, and the other supportive investigation are ESR, Mantoux test, chest X-ray and the ELISA. Disc space gets collapsed when there is infection, but disc space is preserved when there is metastasis. Treatment. We do the ambulant chemotherapy alone. We do the ambulant chemotherapy when the disease is mild, early disease, there is no abscess or there is no neurological involvement. We give ATT, anti-tubercular therapy, according to the category 1 of anti-C ATT regimen, 2 HRJD plus 4 HR for 6 to 12 months. Isoniazid, rifampicin, pyrazinamide and the ethambutol. Isoniazid and rifampicin. Patient is allowed to sit and walk with spine supported. If there is cervical spine TB, then spine is supported with collar and Minerva jacket. If there is dorsolumbar spine tuberculosis, then the spine is supported with ASH brace. We give continuous bed rest and chemotherapy. If the patient has advanced disease, there is no facilities available for the operation, then we give continuous bed rest and chemotherapy for 18 months. 3 HRJD means 3 month HRJD, isoniazid, rifampicin, pyrazinamide and ethambutol, and 15 month isoniazid, rifampicin and ethambutol with high dose of vitamin B6, as we are giving for longer duration, and isoniazid interferes with the metabolism of the vitamin B6. And collar ASH brace is given for immobilization of spine for 2 years. Operative treatment is done if there is drainable abscess and marked bone destruction and neurological deficit and there is marked kyphosis, then we do drainage of the cold abscess. The complications are the cold abscess, which is the commonest complication. Neurological compression can occur, paraplegia can occur. In differential diagnosis, there is prolapsed intervertebral disc, trauma, spinal tumor and the ankylosing spondylitis. Now, Pott's paraplegia. When the TB spine involved when there is neurological involvement in the TB spine, it is called Pott's paraplegia. Types and pathology of paraplegia. Early onset paralysis, which is less than 2 years, or late onset paralysis, which is more than 2 years. In early onset paralysis, there is cold abscess, inflammatory edema, granulation tissue which compress the cord, but it has good prognosis. But in late onset paralysis, there is deformity, fibrosis which directly compress the cord, which has poor prognosis. In Pott's paraplegia has gradual onset mostly. It is spastic to start with. The patient has clonus, ankle or patellar clonus. Here we can see the spinal cord is getting compressed. Normally the paralysis occurs through the steps. Firstly, there is muscle weakness, spasticity. Then there will be paraplegia in extension, then paraplegia in flexion, then complete flaccid paralysis. Now, grades of Pott's paraplegia. There are 4 grades of Pott's paraplegia. In grade 1, patient walk without support. There is no sensory loss. Features of upper motor neuron palsy may present, like spasticity, rigidity, and deep tendon reflex exaggerated. In grade 2, the patient walk with support. In grade 1, walk without support, but in grade 2, walk with support. There is no sensory loss, and feature of upper motor neuron palsy is present, like increased tone, Babinski sign positive, deep tendon reflex exaggerated, spasticity, rigidity. In grade 3, the patient cannot walk. Sensory loss is less than 50%, and features of upper motor neuron palsy is present. In grade 4, the patient cannot walk. Sensory loss is more than 50%, and bladder bowel incontinence is occurred. There is loss of sphincter control and features of lower motor neuron palsy. In grade 1, 2, and 3, there is features of upper motor neuron palsy present, but in grade 4, there is feature of lower motor neuron palsy present, which is flaccidity, tone loss, deep tendon reflex absent, and plantar reflex is also lost. On investigation, we do the MRI to see the type of vertebral destruction, abscess, and cause of paraplegia. For the treatment, stage-wise treatment of Pott's spine is done. If there is grade 1, then we give ATT, rest, and we check the we do the neurological examination monthly. If the patient is improving, then we continue the same treatment. If not, then we do operative management. In grade 2, ATT, rest, and weekly neurological examination. In grade 3, ATT, rest, and daily neurological examination. In grade 4, ATT, decompression and bone grafting is done in grade 4. And in grade 1, grade 2, grade 3, we keep examining neurological examination, and if the patient is improving, then we continue the same treatment. If the patient is not improving, then we do decompression. In operative management, anterolateral decompression is done plus bone grafting, which is the most common. Poor prognostic indicators. If the patient is old, if the Pott's paraplegia is a 4th stage, if the patient have poor socioeconomic status, if there is neurological deficit with healed TB, if there is kyphotic angle more than 60 degree, if there is rapid onset paraplegia. So this is all about tuberculosis of the spine. You can find these notes on the Telegram, and the links are given in the description. Thank you.